luteal phase. This administration is actually estrogen of 2 milligrams twice a day, to be given at least 5 to 7 days prior to the cycle you're going for IVF. Now, this takes us back to physiology. When we have a menstrual cycle, always remember that the FSH starts from the late luteal phase, that is, even before the follicular phase of the next cycle. So when your FSH starts just before your menstruation, it starts 2 days before your menstruation, which means that that's when the FSH starts to rise. And that what is determining the development of a dominant follicle and atresia of the other follicles. So what this estrogen does is, when you are starting it 5 to 7 days earlier, it is stopping that pre-follicular phase or rise of FSH, which means that the dominant follicle is not going to develop, and you will be able to get a complete cohort of follicles which you can utilize for your IVF. So therefore, it decreases your cancellation rates, it improves the number of oocytes and therefore embryos. What about LH? Why do we need LH? We need LH because LH is what increases your androgen production. Why do we need androgens? Because androgen is what actually makes the smaller antral follicles more responsive to your FSH. So it enhances the response to your FSH, which is going to be administered soon. And not only that, it also has a direct effect on oocyte maturation. Now, this actual systemic review also said the same thing. If you have an older person, that is somebody who's older than 37, or if you have somebody who's younger but not responding well, LH co-administration actually makes a difference in terms of outcomes. What about growth hormone? Let's first look at how growth hormone works. We realize that we need insulin-like growth factor. These are factors that are present on the granulosa cells. And if growth hormone is administered, it actually activates the folliculogenesis as well as the granulosa cell function, which makes your oocyte quality better and also improves the response to your FSH injections. And this is what even this Cochrane review said. There was a significant improvement of live birth rate when growth hormone has been added. What about androgen pre-treatment? This has been a bit of a black sheep in terms of fertility treatments, because you have two groups of people, somebody who actually proponents androgen administration and some who don't. But what are the options that we have for androgen pre-treatment? You have DHEAS, which is given either as 25 milligrams 3 times a day or 75 milligrams in tapered doses, or you have the option of testosterone gel. Again, let's look at the physiology. How does testosterone pre-treatment help in terms of folliculogenesis? Again, when we really look at the steroidogenesis, that is the substrate. That is a substrate which actually gets converted to estrogen. When we are looking at the gonadotropin 2 cell theory. So this is the substrate, and when this substrate is deficient, you have follicles which are not going to be as responsive to the gonadotropin injections that you're giving. So when you pre-treat them with androgens, it gives you the substrate which actually makes the follicle more responsive to your gonadotropins. And even a recent meta-analysis has come up to say that giving DHEA or even testosterone pre-treatment actually improves your outcomes. And again, what is the rationale? There's an expression of IGF-1 even through the androgens, not just with growth hormone, but even with androgens. And it promotes the oocyte and follicle maturations. And the dosage that we can give in terms of testosterone gel is 12.5 milligrams per day. Now, also this Cochrane review, which was recent, also identified that women who can be identified as poor responders, whether they are young or old, if they have been identified as somebody who are likely to show poor response, pre-treating them with either DHEA or testosterone might improve your live birth rate. Again, what about trigger? Now, this is where we are talking about nowadays, most of our cycles, we have converted to giving dual trigger. What do I mean by dual trigger? When you're giving an antagonist protocol, you have the option of giving not just HCG, but also an agonist. And again, when you look back at the physiology, HCG actually stays in your system for at least 5 to 7 days. But it takes at least 24 hours before it actually shows any action in terms of raising your LH. But if you give an agonist, it increases your LH 4 hours after administration. So once you give an agonist, what it actually does is it increases your LH immediately in 4 hours. And by the time that comes off your serum levels, your HCG takes over. So what it actually does is the dual trigger, by giving both these triggers together, you are enhancing the LH activity much longer, and therefore you're able to get more mature oocytes. Now, this is one thing which has actually changed the management of poor responders, and that is pooling. What do I mean by pooling? We mean accumulation of oocytes or embryos, which means that when you have multiple eggs that have been collected over multiple cycles, there are less ET cancellations, because you're not going to do a transfer till you have a good group of embryos that have been created. It will significantly reduce your dropout. Now, rather than putting through a woman and putting back one day 3, if you actually go for 2-3 cycles and it accumulate 2 or 3 embryos, she has a better chance of a pregnancy. Therefore, it's less likely that she'll drop out after one cycle. It also reduces, obviously, your psychological distress causing because of repeated failures, and obviously a higher live birth rate per intention to treat, not per cycle. It's per intention to treat patient. So per patient, when you're looking at the live birth rate, because she's undergone 2 or 3 cycles, there's much higher live birth rate than going per cycle. But obviously there are disadvantages. The disadvantages are, what if that woman would have conceived with the first embryo that you put back? Then obviously the multiple embryos that you have created may not have been useful. And the second thing, which actually is more important for the woman, is the cost. This is where we come, finally, is what has actually changed the dynamics of stimulation for a poor responder is double stimulation. What do we mean by double stimulation is that in a cycle, traditionally, what we have understood is that in a follicular wave, you have one dominant follicle, and after the follicle actually ruptures, the rest of the follicles undergo atresia, and the next follicular wave is only in the next menstrual cycle. But that's not true. What we have realized over the last decade, again, is this. Every menstrual cycle, you will have at least 2 to 3 follicular waves, which means that in a cycle, it is not just one dominant follicle that can develop. If you look at the way the follicles develop, you can have at least 2 to 3 follicular waves in one menstrual cycle. So how do we actually utilize this phenomenon in stimulation? What we actually do is, in a cycle, in the follicular phase, we go for a stimulation. Traditionally, we go for extraction of the eggs. And then after the extraction of the eggs, the second day post the collection of the eggs, we restart the stimulation. Why do we do that? Is because when we are really looking at the antral follicle count, we are only able to pick up the follicles that have crossed 14 millimeters. But if you notice carefully, in some of these women, you will still have follicles which are in the range from 5 to 8 millimeters. And somebody who's got less number of eggs, who's only developing only 2 or 3 eggs, even those 2 or 3 follicles that are small are still viable and for something that you could pick up. Let's give you an example. A woman who's 36-year-old, secondary infertility. She had a natural conception before, which ended in a missed miscarriage. She's a BMI of 26. But look at her day 2 investigation. She had an FSH of 27, an LH of 12, an E2 of 0.8, and her AMH was 0.8. And when you looked at the antral follicle count, she had only 2 follicles. And the left ovary was really very tiny, and we couldn't see any follicles. There was no male factor. And she's had 4 previous cycles of IUI. So what we did was, like we discussed, the dosage of drug in somebody who's got only 2 antral follicles, there's no point in us going beyond 300. So we started with 300 units of gonadotropin. And then what we did was, this is the response that she had. So those 2 follicles, the left side, like I told you, was very small and we didn't see any follicles. But other than the 2, there was also another one that developed. So we retrieved 2 oocytes. Both of them were mature, one only fertilized. And fortunately, we got one day 5. But because we saw some more smaller follicles, and on the right side, we saw 3, on the left, previously where we couldn't see follicles, we actually saw 2 follicles. And therefore, we restarted the double stimulation 2 days after the pickup. And we gave her approximately 375, and look at the response now. Same woman, look at her follicular phase response and look at her luteal phase response. Here we got 7 oocytes. And this is a woman who had only an AMH of 0.8. And during her follicular phase, you only saw 2 follicles. Here we got 7 oocytes, of which 6 were mature, 6 fertilized, and we had 2 day 5 blasts. So all in all, we had 3 blastocysts from a woman who had an AMH of 0.8. Let me give you another example. This is a 39-year-old woman, secondary infertility, all natural conceptions. 2, she had 5 weeks miscarriage, and she also had a 4.5-year-old child. Her BMI was 26, and here again the FSH was 22, and AMH was only 0.56. And here on the right side, we couldn't see any follicles, and on the left, we could see 5 or 6. So again, we started with 225, and this was the response. Again, like I said, we could only see follicles on the left side, and that's how the response was. We got 4 oocytes, of which 3 were mature and 3 cleaved. And again, from the second day of her pickup, we started letrozole, and then we restarted also gonadotropin injections for her, which was 225 plus 75, and this was the response the next time. So we got 3 mature oocytes the second time, 3 were mature, 3 fertilized, and 2 cleaved to 6 cell on day 3. And on day 5, we had 2 blastocysts, 1 grade 2 and 1 grade 3. So again, the point that we are trying to make is this way of actually stimulating somebody in which after the pickup, you can still see follicles. That means that you're able to do a double stimulation in 1 menstrual cycle. So in 1 month, you're able to go for 2 stimulations and pull up and accumulate the number of embryos. Again, this is a woman who, again, had very low reserve. And this, in the first stimulation itself, it took us 14 days for us to get to that point, on which we got 5 oocytes, 5 were mature, 4 fertilized, and we got 2 blastocysts on day 5. And we went on to do a frozen embryo transfer. Now, these were some of the things that are currently available for us in terms of options for these women. But what is it that we are looking ahead? What is there on the anvil? These are still experimental, but there's a lot of work being done here. Oocyte activation. What do we mean by this? In Japan, you have researchers which are actually looking at taking a bit of your cortex from the ovary laparoscopically. They actually mince the tissue, the cortex, into small little tissues, and they add on factors, growth factors. What they're actually trying to do is initiate the AMP pathways for them so that they can initiate the process of folliculogenesis. And what they do is they reinsert this tissue back again under the cortex of the ovary so that it initiates more follicles for further few months. That is one aspect. The second aspect is ovarian tissue vitrification. What do I mean by that? Now, remember when we are talking about the history, we said that what if you have a woman who's got a history in a family in terms of premature menopause? What do? What if you see somebody who's got a mosaic Turner? She's young now, but it's very likely that once she turns 30 or a little older, she might again get menopausal. So in these women or somebody who's got autoimmune conditions, you know that the immunity is going to reach such a level that she might get menopausal. So in these group of women, when you catch them early, what is possible is even sometimes this has been used for prolonging your perimenopause. So what do? We go laparoscopically, we remove a piece of the cortex and we vitrify it. And if a woman prematurely goes into menopause, we reinsert this cortical tissue back under the cortex so that folliculogenesis and hormones are produced further and we can actually delay her menopause. Ovarian rejuvenation. A lot of work again being done on this, though we haven't reached any conclusion in terms of intra-ovarian stem cells and PRP. Now, these are the fields that we have to look forward so that we can actually come to some conclusion in how to treat these women with low response or poor reserve. Conclusion, young women with low reserve do better than old normal reserve. So even if you see a 29-year-old woman with a 0.8 AMH, she will definitely do better than a 35-year-old woman with an AMH of 2. Age trumps everything. In women with low ovarian response, no differences exist in terms of safety and efficacy between either the agonist or the antagonist protocol. Doses higher than 300 might not be of great advantage. Choosing recombinant over urinary gonadotropins also is not supported by strong evidence. Addition of LH or even growth factors, growth hormone, may benefit women with advanced age or even young women who are not responding well. Pre-cycle adjuvants such as DHEA, estrogen priming, testosterone gel priming may be beneficial, but you still need more data towards that. Dual stim is promising and definitely here to stay. And pooling of embryos must be considered, and these should be given a chance before we tell them that their oocytes are not capable of giving them a pregnancy and consider donor. Thank you.
Thank you, Durga ma'am. That was an excellent and very informative talk. Hopefully we give respect to couples' choice and try in helping them to have their own biological child. So now we move ahead to the panel discussion. I'll be taking the privilege of moderating the panel discussion on some challenging cases in infertility. Now I call upon Dr. Durgaji ma'am for a panel discussion. Dr. Durgaji is co-founder and medical director and infertility specialist and gynecologist practicing in Oasis Fertility. Dr. M. Padmaja ma'am. Dr. Padmaja ma'am has done her MS from JSS Medical College, Mysore. She has several years of experience and recognition to her credit in the field of obstetrics and gynecology. She worked as a consultant in RDT Spain organization, RDT Hospital Spain organization, and she is a medical director of Mother Hospital in Tirupati. And she is a renowned obstetrician and gynecologist. Madam, please come on to the dais. Dr. K. Neelima ma'am. Dr. Neelima has over 19 years of experience in the field of obstetrics and gynecology. She has done her MBBS from Kakatiya Medical College, Warangal. She did her post-graduation from Osmania Medical College, and she did her DNB from SRMC, Chennai. She is a medical director of obstetrics and gynec hospital, and she is a laparoscopic surgeon. Dr. K. Ramchandra sir. Dr. Ramchandra sir is a consultant gynecologist, laparoscopic surgeon, IVF specialist at Manohar Super Speciality Hospital and IVF Center in Tirupati. Is professor and associate professor, past in Shantiram Medical College, Nandyal. He has served as assistant professor of Obgyn at Government Medical College, SVMC. He did his senior residency at Jipmar, Pondicherry, and junior residency at AIMS, New Delhi, and ex-IMA president, Tirupati. I take the privilege of inviting Dr. Ramchandra sir, a senior consultant gynecologist in Tirupati, onto the dais. Dr. Suresh sir, urologist and medical director of Suguna Kidney Center in Tirupati. Please come on to the dais, sir. Dr. Manikarnika madam, medical director of Manikarnika Hospital. She is the founder of Manikarnika Hospital. She did her MBBS from SVMC Medical College, and she did DGO from Government Medical Hospital, Tirupati, and she is a consultant obstetrician, gynecologist, and laparoscopic surgeon.
Can I ask, madam, for the excellent lecture, I congratulate Dr. Durgarao. Madam, may I know what is the role, by giving dual stimulation, in your experience, is there any high incidence of OHS?
So the risk of OHSS is somebody who has a good ovarian reserve. And what we mean by good ovarian reserve is somebody who's already got an antral follicle count of more than 10 on each follicles, on each ovary rather. And what we were speaking about is a poor ovarian reserve. So these people actually have a combined AFC of less than 10 anyway. So the risk of OHS is very low. And what we are also doing actually is when we finish the extraction of the oocytes, we put them on letrozole. So when we're putting them on letrozole, we're actually reducing their serum estrogen anyway, which makes them much more responsive to the second stimulation and reduces the risk of OHSS also. So we keep their estrogen levels low right after the OPU.
Now I'll start the session for panel discussion, challenging cases in infertility. So first we'll move ahead with the case number 1. Mrs. A, 28 years, female. Mr. B, 34 years, male, married for 8 years with primary infertility with BMI 25. She is a known case of PCOS with irregular cycles with 30 to 90 days cycle length and on ultrasound, polycystic ovarian morphology with no evidence of clinical or biochemical hyperandrogenemia. On medical history, she is a hypothyroid and she is on medication since many years. No significant family or personal history. So coming to her previous treatment history, she underwent multiple ovulation induction and timed intercourse cycles with oral ovulogens and gonadotropins at multiple clinics, details of which are not available, almost for 4 years. Later on, she has underwent hysterosalpingogram and bilateral tubes were patent in that. Then she has taken 2 more cycles of IUI at a private clinic, wherein she was given letrozole 2.5 milligrams for 5 days and urinary FSH 75 international unit for 2 to 3 days. Ovulation was documented. Endometrial thickness pattern were optimum as per scan images, but there were no details on semen analysis. It's now 7 years since she started to try. So Dr. Padmaja madam, do PCOS have all the time in the world because their AMH is on the higher side, and how many maximum induction cycles she can try?
Yeah, see, she can, they can try for 6 to 8 cycles of IUI generally. If the age is less than 35 years, as the patient's age is still less, then I can consider for laparoscopy ovarian drilling also in this case once again. And yeah. So we can try diagnostic lab and drilling, and further we can try on as age is less.
Yes. So her previous investigations, female partner AMH is 8.6, FSH, LH are normal, LH higher than FSH, vitamin D, TSH, prolactin, and GTT are within normal limits. And male partner evaluation is 36 years old, government employee by occupation, BMI 27, no history of smoking or alcohol history, no other medical or surgical illness, no significant family history, and semen analysis showing 23.6 million per ml count and 37% rapidly progressive motile sperm, 16% slow progressive motile sperms, and 6% non-progressive sperms, 11% normal forms. So then she underwent, as ma'am rightly said, she underwent hysterolaparoscopy in 2018. Uterus was normal, ovaries were PCOS morphology, bilateral ovarian drilling was done, bilateral tubes were tested, they were normal looking, and both the tubes were patent on chromoperturbation test, and on hysteroscopy, uterine cavity was normal. So she underwent laparoscopic ovarian drilling. So Dr. Neelima ma'am, what is your thoughts on laparoscopic ovarian drilling?
When we have the opportunity to do a laparoscopy, LOD becomes the first place, and then the pelvis is evaluated for any adhesions or endometriosis, and along with that, hysteroscopy is mandatory to look at the endometrium. So when we do a laparoscopic ovarian drilling, we have to definitely follow the rule of 4, sticking on to only 4 punctures per ovary, and 4 seconds each puncture, and around the power limit also. So stick to this rule, followed by irrigation of the ovary. So after laparoscopic ovarian drilling, the advantage is doesn't need intensive follow-up, and monofollicular ovulation is very evident, and there is no risk of OHSS, obviously. So the success rate, I think it's maximum in the first 12 months, and that's it. And simultaneously evaluation of the pelvis and the uterine cavity also.
Yes. Yes, madam. For brushing up for the students here, advantages of laparoscopic ovarian drilling, spontaneous monoovulation. It is as effective as gonadotropin. It requires less monitoring compared to gonadotropin treatment. There is no risk of ovarian hyperstimulation syndrome and no risk of multiple pregnancy. But this should not be the first line therapy. It should be opted only in selected cases, like in CC resistant, clomiphene citrate resistant PCOS cases, as an alternative to gonadotropins. And in women with PCOS with high LH, normal BMI, and when there is any additional pelvic pathology which has to be ruled out, or when women cannot come for intensive follow-up for the regular checkups. So, but the disadvantages with LOD would be surgical complications, infection, iatrogenic adhesions, and decreased ovarian reserve if aggressive puncturing is done. So as madam rightly said, rule of 4. So this is like 4 punctures per ovary, each for 4 seconds, 40 watts power setting, and with the lowest effective dose delivering 640 joules of energy per ovary. So how does this drilling help? The mechanism of action would be it removes mechanical barrier and helps the release of the oocyte. It destroys androgen producing stroma, leading to decreased circulating androgen levels, and also it increases insulin growth factor 1, which increases the levels of FSH and FSH response to the response of the follicles. So then the story continues. She then underwent 2 more cycles of IUI with oral ovulogents and gonadotropins, and ovulation was documented in each IUI. And post-processing, semen was showing 20 million per ml of count and 60 to 70% of motility. So, Dr. Manikanka, madam, how many more IUI cycles are justified in this case scenario, and what would be your practical experience on this, ma'am?
I will suggest usually 3 to 6 cycles of IUI. Then after you go for alternate therapy of ARTs are that. I will suggest.
So, how many cycles of IUI? According to studies, pregnancies resulting from IUI occur during the first 3 to 6 treatment cycles. Most women conceive after 4 to 6 cycles of IUI, and cycle fecundity declines by half to two-thirds thereafter. And NICE fertility guidelines says up to 6 IUI cycles can be tried for women with unexplained infertility, male subfertility, cervical factor, and minimum to mild grade 1 endometriosis. And when we look at the cumulative IUI success rates, maximum up to 3 cycles can be tried, and after third cycle, fourth cycle, from fourth cycle, the success rate becomes plateau. In the first cycle, around 63% success rate can be expected. In the second cycle, 19.7%. Third cycle, it gradually declines, and then it becomes plateau. So then she underwent an IVF cycle in 2019 in ANTAC protocol. With ANTAC protocol, it was a 9 days of stimulation. She has been given 225 international unit of Gonal-F injection, and Lupride trigger was planned. E2 on the day of trigger was 2171 picograms per ml. After pickup, 18 oocytes were retrieved. Out of that, 18 were M2. They were of good quality. ICSI was done. 18 got fertilized, 18 got cleaved. On day 3, she got 11 grade C embryos, and they were discarded. No embryos were available for transfer. So this was the treatment in outside hospital. So Dr. Neelima madam, can you explain us the role of vitamin D in PCOS?
Vitamin D actually is supposed to be involved in all the metabolisms. So it is the main calcium regulation and parathyroid hormone down regulation. So low levels of vitamin D are associated with higher incidence of infertility and ovulatory dysfunction. So we always try to maintain the vitamin D in the normal levels.
And suboptimal vitamin D levels in PCOS were implicated in disrupted reproductive hormone balance, including overproduction of anti-Mullerian hormone, accumulation of pro-inflammatory advanced glycation end products, and formation of reactive oxygen species in ovarian tissue, leading to abnormal folliculogenesis. And a randomized control trial published in RBE 2018 says the supported that 50,000 international unit vitamin D supplementation every other week for 8 weeks had beneficial effects on insulin metabolism and lipid profile of infertile women with PCOS who are the candidates for IVF. And when we look at the subclinical hypothyroidism and impact on fertility, Dr. Manikannika ma'am, can you enumerate about subclinical hypothyroidism and impact on infertility?
Clinical hypothyroidism causes menstrual irregularities, anovulation, infertility, so and miscarriages. So we need to treat that before planning our pregnancy treatment and outcome. Yes.
So let us quickly look at what guidelines are saying. According to ASRM Practice Committee published in 2015, there is fair evidence that subclinical hypothyroidism defined as TSH more than 4 is associated with miscarriages, but insufficient evidence that TSH 2.5 to 4 are associated with miscarriage. There is fair evidence that treatment of subclinical hypothyroidism when TSH levels more than 4 is associated with improved pregnancy rates and decreased miscarriage rates. And during the first trimester of pregnancy, it is advisable to treat when the TSH is more than 2.5. And there is fair evidence that thyroid autoimmunity is associated with miscarriage and fair evidence that it is associated with infertility. While thyroid antibody testing is not routinely recommended, one might consider testing anti-TPO for repeated TSH values more than 2.5 or when other factors for thyroid disease are present. If anti-TPO antibodies are detected, TSH level should be checked and treatment should be considered if the TSH level is over 2.5 milli international unit per ml. So then she came to Oasis and course at Oasis. Female partner was evaluated. AMH was 5.14, LH was 6.23. It was more than FSH. TSH, prolactin, glucose tolerance test were all within normal limits. On TVS, antral follicle count in the right side was 8 to 10, and the left side it was 8 to 10. So semen analysis in male partner was showing 30 million count per ml, 15% progressive motility, and 2% normal forms. So he was advised DNA fragmentation index, and it was high, it was 48%. So Dr. Durga ma'am, what are the causes for high DFI, and in whom it has to be checked routinely, and how to go about managing high DFI cases?
I think my colleague, Dr. Urologist, would be the best person to answer this, but before
Yes.
him, I'll just take a brief thing. When we are talking about raised DNA fragmentation, I think the most common factor that we tend to see is varicoceles and infection. And there are also other reasons for it in terms of obesity, lifestyle, and other conditions as well. And when we are talking about whom we have to check it in, I think this would be the ideal candidate in whom the embryos did not actually develop beyond a cleavage stage. So somebody who's got a previous poor embryological outcome with their IVF cycle is somebody in whom we would test the DFI in. Obviously, any medical conditions like diabetes also we tend to test the DFI to see what would be the best way of processing the sperm. But I would like to hear the comments of my colleague.
Dr. Suresh sir?
Madam has already highlighted many of the things, but this DFI usually varicocele, from our perspective, andrologist perspective, varicocele is important. Infections, all these are more important. So unexplained miscarriages, unexplained infertility. In these cases also we go about doing DFI.
So some of the other common causes for raised DNA fragmentation index are aging, and habits like smoking, chronic smoking, alcohol, stress, and exposure to pollutants, toxins, radiation, and high intake of caffeine, and increased testicular temperature, presence of varicocele, high BMI, obesity. So these are the common causes for high DNA fragmentation index. So how is it going to impact the ART outcomes? High DFI might cause fertilization failure. It might result in poor embryo quality, implantation defects, spontaneous miscarriages, and sometimes congenital malformations. So in whom DNA fragmentation has to be tested? So this is usually indicated in women with unexplained infertility, in couples with repeated miscarriages, with multiple failed IUI cycles, and couples who had previous IVF failure. So course at Oasis, she was given a pre-treatment with vitamin D, metformin 1 gram, and myoinositol for 6 weeks. And she was taken for an IVF cycle with ANTAC protocol. She was stimulated with injection recombinant FSH 150 and HMG 75. ANTAC was started from day 6 of stimulation. She was supplemented with growth hormone 6 units for 11 days. And total dose of gonadotropin she consumed was around 2,500. And on the day of trigger, E2 levels were 6,720. So a dual trigger was planned with low dose HCG 1500 international unit along with triptorelin 0.2 milligrams, 2 doses 12 hours apart. OPU was done 35 hours later. And then husband has given the fresh ejaculate and microfluid. It was showing 32 million per ml, 70% rapidly progressive sperms, 10% slowly progressive sperms with 1% normal forms. Microfluidics sperm selection method was done on fresh ejaculate. He was also supplemented with antioxidants 2 months prior IVF and was advised to take daily ejaculate for 10 days before ovarian stimulation. So 16 oocytes were expected. She got 18 oocytes, and out of that, 17 were M2. Oocyte quality was average. She got 13 day 3 embryos. 13 were grade 3, 1 grade 2, and 1 grade 1. 2 embryos were frozen on day 3 since looking at her previous history, and all other embryos were cultured to day 5. She got 1 blastocyst, 3 AB, grade 3. And FET was planned further. So, Dr. Durga ma'am, can you enumerate us or enlighten us about the role of growth hormone in PCOS? And do you suggest any other pre-treatment in this case, madam?
I think when we are talking about PCOS, the most important thing is starting from the basics in terms of ensuring that she's of ideal weight. We take care of her lifestyle in terms of her weight, her general body habitus. And also, the most important thing I think is somebody who's had a previous failure like that in terms of her oocyte quality, she should be given adequate pre-treatment. And what has been seen most recently is myoinositol with melatonin being the good antioxidants actually tend to improve the quality of the oocytes. So I think lifestyle management as well as a good antioxidants with myoinositol would be the pre-treatment that we would suggest. So would you like to add?
The previous one regarding the first PCOS, the ovarian stimulation, we prefer or what the usually the books says, three cycles always you give whatever letrozole or previously we are giving clomiphene, now with the letrozole. So apart from what madam has told, the first weight reduction, at least 5 to 10%. Majority they will ask. So how much the weight reduction? We cannot expect a lean like whatever the beauty queens. We only 5 to 10% of the weight reduction, mainly the visceral fat. If there is a reduction, definitely ovulation with metformin alone, apart from even the, whatever the drug comparatively, they now we go for other drugs which madam has told, melatonin, other drugs. So first line of management is weight reduction. Second is the metformin. And then we go for induction for 3 cycles. If any woman not conceiving after 3 cycles of ovulation, we prefer to go for ovarian drilling. This ovarian drilling, majority of our IVF experts nowadays, they may not agree because unnecessarily the youngsters, they may overzealously decrease the AMH by doing many punctures. So always remember for junior's sake. So 4 punctures what madam has told already. And always you do the irrigation after doing majority of the cooling of the ovary and removing the toxins, which whatever the androgen fluid which has come out from the ovary, definitely will prevent. Last time I am showing a slide also. Out of my own personal experiences of 6,000 seizures, no single case of addition, where in addition I have seen following 10,000 cases of PCOS ovarian drilling. Out of that, 60% of them have conceived. So excellent results with, if in good hands, very simple surgery, we will get good outcome. And definitely, even if we got our ART clinics mushrooming, still there is a place of ovarian drilling. That is about, so additions, you need not worry at all about the addition if you are following the basic principles of surgery in laparoscopy. There, I think the additions, unlike open surgery, we cannot expect. That is about the induction and PCOS. And other thing what?
Sir, after LOD, how long we can wait, sir, for the natural conception?
I usually, my preference is 1 month abstinence after the ovarian drilling. Any patient after the drilling, then only we are going for induction. But natural conceivement, we are not waiting. Most of the patients require definitely after the ovarian drilling also, either letrozole or with HMG, we are with HCG follow up and followed by Profeston or whatever dydrogesterone we follow. That majority, most of the people I have seen within 1 year or within 3 months, majority will conceive. But occasionally we will see, even after 2 years, we have done early, and the patient will escape without any treatment, they will come. So even though books says up to 9 years, ovarian drilling will last. In my personally, I have seen 2 years after 3 years also. And please remember, there is no place of any second time ovarian drilling. So that previous doctor might have not ovarian, the other not done well, so I will do better. Like that, not to do practice at all. So once if anybody who has done, definitely it is a minimal procedure. We don't expect any like endometriosis and expert surgery. So whatever, whoever the surgeon, we should believe and not to go for again. So if they have failure is there more than 1 year, go for ART only. So thank you.
Madam, would you like to add any of your
So
practical
actually, I have
experience?
seen many patients who have conceived in the same cycle after ovarian drilling. Same cycle. And I don't agree with sir in one thing. Don't repeat drilling, because I've seen patients who have not affordable, like who can't go for ARTs. So if they have done like drilling 2-3 years or 5 years back, and they come again for infertility's sake, at least after more than 3-4 years, I think ovarian drilling still helps if they get it done second time. That's my experience.
Dr. Padmaja, what is the legal standing that we should know? Because no, indiscriminately we cannot tell like that. So there are instances, even the books previously, the literature shows also, in very few cases, second time ovarian drilling is advocated. But now
I don't
with,
think there's any legal issue, sir, if you do a drilling in a
yeah,
second
if
sitting.
AMH will definitely fall, if the patient can if they go to the court, what is our stand, we should know. But madam, what is your experience? No, I think legally, I think we should not decrease the
There
AMH.
is no literature to support second drilling, madam.
Second.
Actually, that's what, at least as far as literature is concerned, drilling when done once, if it hasn't helped, then we have to again go back to the basics as to why drilling also did not help. And here again, selection of the patient for drilling is very important. You have to take somebody who's lean, who's hyperandrogenic, whose LH is not very high. In those people's drilling would help. So if drilling did not help the first time, probably the selection of the patient was a problem rather than the procedure itself. So I think we need to look back and see and ensure that, again, lifestyle management, giving them metformin, putting them on these might give them a better chance rather than doing the second drilling.
And if drilling is done, is there any effect on ovarian response if the same patient goes for an IVF cycle later on, if she doesn't conceive with natural conception?
Definitely. That is why we are worried. Nowadays, majority of the infertility ART specialists are questioning whether we should go for ovarian drilling at all or not. So leave alone the second, what Dr. Padmaja says. The first time also we should do it or not is questionable nowadays. So in this era, I think the place of ovarian drilling is there in our rural areas where majority may not accept straight away for ovarian, ART clinic in ART. So better you try minimal. Then if the patient is not considered within 6 months or 1 year with all of your modalities, then I think better we go for ART.
So the take-home message from this case is, it's not the quantity but the quality that matters. Be cautious before offering laparoscopic ovarian drilling for the patient. Elderly PCO, treat with little more caution. Protocol should be individualized. OHS-free clinic is the dictum. Consider checking DFI in cases of unexplained infertility, recurrent implantation failure, recurrent pregnancy loss, smokers, male with obesity, varicocele, and mere parameters are also to be closely monitored. So now coming to the second case, Mrs. N, 32 years female, and Mr. R, 37 years male, married for 7 years, secondary infertility. She had regular menstrual cycles, 28 to 30 days once. She's a known case of hypothyroidism on medication. And her obstetric history, she had first pregnancy, which was spontaneous 6 years back, and she delivered twin children, male and female. Male child got expired after 2 years of birth due to some infections caused. Then after delivery, she underwent laparoscopic sterilization 6 months post-delivery and tubal recanalization. As the male child has expired, she has underwent tubal recanalization 4 years back, and post-surgery, HSG was done and it was showing bilateral tubal block. So what is your take on recanalization surgery versus IVF, sir, Dr. Ramchandra, sir?
Last time also I am discussing with expert tubal recanalization decanalization expert Dr. P.G. Paul in last time ISAR at Mumbai. So definitely there is a place of surgery in the reproductive surgery for recanalization enhancing. But with in good hands, with the success rate is around 60 to 70%. But majority of the patients are rural throughout India. There were very few experts. I mean, microscopic surgery is done. With macro surgery, the success rate, as we know, may be ranging from 30 to 40 or maximum 50%. So definitely, the patients who can afford, we prefer directly going for ART instead of going for IVF. I mean, recanalization may be helpful. Those who cannot, afford for the recanalization, other surgeries, they can opt for ART straight away also. In government setup, what is the rationale? I think either Dr. Bharati or Pars has ready to tell. What is the, we can, unless there is ART clinics from the government sector, so straight away we cannot advise them to go to a private clinic like Oasis or somebody else. So what is the, they should answer, I think, on the government sector people. So we, number of ART clinics also should come in the government sector also. Apart from, or we should train the surgeons in laparoscopic microsurgery, the good results will come where, because still we got role of, even though we are worried about the infertility, still there is a role of tubectomy or whatever sterilization role. So what is the rationale? They should answer, better persons, so they can guide or they can recommend to the government to set up more ART clinics or expert lab surgeons. Thank you.
And do we have any prognostic indicators or prognostic factors to suggest recanalization procedure for the patient?
Yeah,
Do we look at any prognostic factors?
definitely, if the length of the tube is less than 4 centimeters, definitely the chance of success rate will be very poor. The chance of ectopic also very high. So in such patients also, our ART clinics will definitely play a good role.
Thank you, sir. So, looking at the studies, this is an article published in Fertility Sterility in 2021. So, patient age, role of tubal surgery in the era of ART. It's a committee opinion. So, patient age, ovarian reserve, partner semen quality, surgical technique that was used to perform the sterilization before, the cost factor, chance of success, and reproductive preferences. These are the essential elements in decision making. Tubal recanalization versus IVF treatment. Other prognostic indicators which are thought to predict success include final tubal length and the site of tubal reapproximation. Isthmic reversals may have greater success than ampullary or cornual segments. And the rate of ectopic pregnancy after tubal anastomosis was reported as 4 to 8% in tubal recanalization versus 1.4% for IVF. Women who elect tubal reanastomosis require early surveillance with the occurrence of a positive pregnancy test. And if no pregnancy occurs within 6 months, an assessment of tubal patency is suggested. So, the male partner was evaluated. He was 37 years old. His semen parameters were showing 15 million per ml count, 5% progressive motility, 1% non-progressive, and 1% normal forms. On ultrasound scrotum, right testis and left testis were normal size. Right epididymis was, both the epididymis were normal, but bilateral varicocele was there. Right side grade 2 and left side grade 3. He was advised varicocelectomy by andrologist, and his DFI was also high with 35%. So, Dr. Suresh, sir, do we advise varicocele surgery for all infertility patients? And what should be counseled prior to varicocele procedure?
Actually, we don't advise varicocelectomy for all the patients. So actually, many of the varicocele, 80% of the varicocele patients, retrogradely we see, they would have fathered a child. So there are only some specific indications. So the mainly the grade 2 and grade 3. what we see clinically, not radiological grading. So we do in those patients with abnormal semen parameters. And when this varicocele surgery we are doing, if FSH is high or if the testosterone levels are low and the volume of the test is low and subclinical varicoceles, we say no. So these are the patients where we don't actually, they don't fare well or don't do better on a
With
varicocele
poor
surgery.
prognosis.
Poor prognosis. Then we counsel all the patient, all the complications of varicocele surgery. So best one is now what we do is actually subinguinal microscopic surgery is the standard of care. So there are so many other things, embolization and laparoscopic varicocelectomy. And of course, way back we have given up the conventional open surgeries, Palamo technique and all those things. But we have to counsel the surgical things. And usually we wait for 3 cycles, at least 3 to 6 months to see the
After the surgery.
after the surgery. So usually the quality semen sperms appear around 6 months. We have to wait for minimum 6 months. Then they go up to 2 years. Then they plateau out. So this happens after varicocele surgery. So the surgical complications and real natural course post varicocele, how the semen parameters we have to explain to the patient before taking up for the varicocele surgery.
Sir, after surgery, how long we can wait for natural conception, sir, after the surgery, if the couple is willing for a natural conception?
Actually, I told no, 3 cycles we have to ideally wait, and ideally it amounts to 6 months.
Sir, if there is
6
any
months.
recurrence of varicocele
Yes.
after the first surgery, in such cases, do you suggest any resurgery or?
Yes, we can do it. Revision surgery can always be taken up. Usually, some of the anatomical revisions we usually go for venograms, and we can go for embolization, and then again a open surgery for the failed varicocele surgeries.
So what could be the causes for varicocele, sir? Like, I mean, the couple in front of us will be asking us, so I am healthy, I doesn't have any health issues. Why does I get this varicocele?
Left vein, that whatever Pamperon flexus comes from the left side, it is a direct, it doesn't contain walls. And sometimes it is compressed by the renal veins. It's called nutcracker effect. So isolated right side of varicocele you see. So you should be very cautious because it can be due to a neoplasm, RCC, renal cell carcinoma. So left side are usually the most common side. Left side varicocele you see. Isolated right side, be wary about RCC. Don't jump. You should not jump and advise a surgery. So usually left side is common because of the long vein. The column of vein pressures are high on the left side, and nutcracker effect is one more thing. This all amount to more common on the left side. Majority, as I have told again, I want to emphasize that many of the parents or fathers who have parented their child, they have 80% have a varicocele.
Thank you, sir. Sir has very well explained us about varicocele and has given his thoughts about, practical experience about varicocele surgery and its prognosis. Thank you very much, sir. So, according to SRM guideline, surgical varicocelectomy should be considered in men attempting to conceive who have palpable varicocele, infertility, and abnormal semen parameters, except for azoospermic men. Clinicians should not recommend varicocelectomy for men with non-palpable varicoceles detected solely by imaging, as sir has rightly pointed. For men with clinical varicocele and non-obstructive azoospermia, couples should be informed of the absence of definitive evidence supporting varicocele repair prior to ART. And conservative management of varicocele is recommended when there is no clear indication for varicocelectomy, along with regular follow-up by semen analysis and hormonal profile for early detection of deterioration in testicular function. Reduced preoperative testicular volume, elevated serum FSH levels, diminished testosterone concentrations, and subclinical varicocele are negative predictors for fertility improvement after surgery. So investigations that are done at Oasis, AMH was done, it was 0.79. Transvaginal sonography was showing antral follicle count 4 in the right side and 2 to 3 in the left side. She was having an endometrioma of 2.5 to 3 centimeters in left ovary. So, Dr. Padmaja, ma'am, do we suggest endometriotics? Do you suggest all endometriotic cysts need to be operated? And excision versus drainage, what is your take, ma'am?
No, endometriotic cysts need not be operated in all the patients. I personally feel that if it is more than 3 or 4 centimeters, then we better interfere. I always prefer to excise the cyst wall versus drainage if it is possible. But in most of the cases, somehow they'll be densely adherent and it's quite difficult to excise the whole cyst wall. So I suggest not to use much of cauterization to prevent the damage to the ovary. So we try maximum to excise, but if not possible, drainage and a less cautery as much as possible.
And in case of grade 3 and grade 4 endometriosis also, do you suggest surgery or do you suggest ART treatment, madam, in such couples?
The endometriotic cyst, if it is like grade 3 or 4, I think even if they want to go for ART in future, natural conception is almost nil. So they have to go for ART. So at least to egg pickup, I think we need to do some sort of surgery to get oocytes, I think, to pick up. I think it will be difficult if the ovaries are adherent. I don't think you can reach the ovaries during ART. What do you suggest, ma'am? What's your opinion about this?
I would agree. I think the accessibility of the ovaries is the most important thing in grade 3 and grade 4. And if there is a problem in terms of accessibility, then yes, surgery would be recommended. Otherwise, we can go straight for ART as you had suggested, Dr. Padmaja.
Thank you, ma'am.
During ART also, most of the times when you go for home pickup, whether when you go through the cyst, what is the chance of abscess formation? So whether we should take back or what is your suggestion?
You're absolutely right, sir. When we are looking at an endometrioma, we would prefer to definitely avoid the endometrioma. Even if you have follicles which are behind the endometrioma and your access is only through the endometrioma, we would rather leave those follicles rather than go and extract oocytes from them. And if at all there is a possibility that inadvertently we have punctured an endometrioma, it's very important that you remove the needle and you wash it because you don't want the oocytes that are going to be taken away to be contaminated by the endometriotic fluid. That's one. And the second thing is the woman has to be on broad spectrum antibiotics, IVs, for at least 72 hours so that you would preempt any kind of infection or pelvic abscess, because that is what is going to actually ruin her fertility even further. Not just the endometriosis, but having a tubo-ovarian abscess.
And recently I've seen a case with grade 3, grade 4 endometriosis. She was taken for laparoscopy and it was a frozen pelvis and they couldn't operate somewhere in Chennai or somewhere. And then it was closed again. Then she came back for an IVF treatment. So when we did transvaginal scan for her, she was having multiple endometriotic cysts in each ovary, like more than 2 to 3. And each were 3 to 4 centimeters in size, bilateral. And it was a frozen pelvis kind of picture. So in such situations, what is your take, ma'am, and what is your practical experience?
Again, in somebody like that, I think the preference in terms of if it was a laparoscopic surgery and they couldn't access it, then if she has symptoms, because the only reason for surgery in somebody like her would be to relieve her of her symptoms. If she's asymptomatic and it's only fertility that is the concern that she has, then we can go for IVF first, extract as many oocytes as possible, but being safe is the most important aspect here. And then, suppress her with either Leupride or Dynogest for some time, reduce the toxins that are being produced by the endometriosis that is so prevalent, and then go for a frozen embryo replacement where her implantations might improve. But if symptoms are
Main
a reason
concern.
for her, then we wouldn't have to even consider a laparotomy if required, because for us, treating her symptoms is more important. So if she is complaining of dysmenorrhea, which has not been treated, which has not been rather treated with medical management, that's only when we would consider surgical. But first, it should be medical management.
Thank you.
There is a in such cases, even in laparoscopy or laparotomy, even if you do laparotomy also, most of the times we are unable to take out.
So this is
Instantly,
where
what
I
is
think you should
any
have.
role of laser here?
Absolutely, but I think it's also more important that when you're doing a surgery, that should be the best surgery for her. So, you don't want to have multiple attempts at it. So even if you require a bowel surgeon there, go into the rectovaginal space, remove your rectovaginal nodules. I think the first surgery has to be the best surgery, because if you leave it again, you're going to cause more adhesions and more complications for her. So I think planning the surgery for somebody like her is very important.
Most of the surgeons will be definitely intermediate surgeons if you talk about endometriosis. Like Gray, who is father of endometriosis, most of the times we cannot go through the rectum or whatever unless somebody is helping, either general surgeon or whatever other surgeon. It's definitely, even general surgeons also, most of them, they are not well used to it. Definitely, an advanced surgeon has a good role for treating an endometriosis.
And nowadays with robotics, I think getting into those spaces, which is more difficult, either laparoscopic or even with laparotomy, with robotics, you're able to actually get to those specific areas as well.
Thank you, madam. So treatment at Oasis, her AMH was 0.79. So she was pre-treated with DHEA, CoQ and vitamin D3 1 month prior to an IVF cycle, and testosterone gel 1 puff per day transdermally was given for 21 days from day 5 to day 25 prior to the IVF cycle, and husband was put on antioxidants. She underwent an anti-IVF protocol, started with clomiphene citrate 100 milligrams for 5 days from day 2 to day 6. Injection HMG 300 was given for 3 days along with growth hormone supplementation. On the day of trigger, E2 was 2800 and dual trigger was planned. HCG 10,000 K along with triptorelin 0.2 milligrams, two doses 12 hours apart were given. OPU was done 35 hours later after trigger injection. And with fresh ejaculate of semen sample, husband semen sample was showing 11 million counts with 5% progressive motility and 3% non-normal forms. Microfluidics was chosen as sperm selection method. And she got total 6 oocytes were retrieved, and ICSI was done on 5 M2 oocytes. 5 got fertilized, and she got 3 day 5 embryos. 2 were 4 AB grade 2 and 1 3BB grade 2. So FET was done with down-regulated luprite HRT cycle. 2 day 5 embryos were transferred, and her beta HCG was 956. So take home message: low reserve doesn't always mean only donor gametes. Cautious judgment before tubal recanalization is required. Not all endometriotic cysts needs surgical management, and adjuvants may have some role in poor responders. So this is the last case for today. Case number 3, Mrs. Yan, 37 years old female, and Mr. Y, 42 years aged male, married for 7 years with secondary infertility, with BMI 30, with regular menstrual cycles, and they have already underwent 3 cycles of donor IUI outside, and it was failed. And she underwent an IVF cycle. It was she conceived in that cycle, but it was a biochemical pregnancy. So her previous investigations were showing AMH 2.3, FSH, LH, prolactin, and TSH were within normal limits. FSH was little on the higher side. Semen analysis was showing 1 million per ml count, 1% progressive motility, and 1% normal forms. Scrotal ultrasound was normal, and he was diagnosed to have severe OATS. So, what other investigations you suggest in a patient with severe OATS, and what is the role of antioxidants in a patient with severe OATS, Dr. Suresh, sir?
In severe OATS, actually, these are many of the times due to intrinsic testicular abnormalities. Some of the things can be due to genetic 7 to 10%, less than 5 million counts are there. 7-10% have a genetic abnormalities also. So in these cases, we have to evaluate we have to get the DFI, all these things we have to evaluate. And mainly we have clinical examination also is important in this type of cases, which will give a clue for further evaluation. So, and regarding the antioxidants, definitely they have got a role in to play. Carnitine, selenium, CoQ, and all these have a role to play. And they don't respond many of the times. They exceed the endpoint.
Thank you, sir. So, coming to role of antioxidants in severe oats, the current systematic review 2021 clearly shows that antioxidant supplementation improves 7 parameters, and another study meta-analysis published in RBMO 2019 showed significant improvement in 7 parameters for selenium, L-carnitine, acetyl L-carnitine, CoQ for oligozoospermia, asthenospermia, and teratozoospermia. So, treatment history outside, she underwent one IVF cycle in 2021. No details were available. It was 11-day stimulation as per her history. 6 oocytes were retrieved, 6 were M2, and on ICSI, total fertilization failure was noticed, and there were no embryos for transfer. Couple were counseled for donor embryos in the same fresh cycle and transferred 2 blasts, 4AA and 4BC. ET was optimum, but it was a biochemical pregnancy. And another second cycle IVF they underwent with the donor embryo, and 2 blasts were transferred, 4AA and 4AB, but transfer was failed. So, investigations at Oasis, scan was done. On pervaginal examination, uterus was 10 weeks in size, irregular shape. Scan was done. There were 2 fibroids of 4 into 3.5 centimeters in fundal region, 3 into 3 centimeters fibroid in anterior wall, just in contact with endometrium, 2 to 3 small intramural fibroids, 1 to 2 centimeters in posterior wall. 3D scan was showing no indentation of the cavity. Anterior wall fibroid was just touching the cavity. She was having 6 follicles in the right side and 7 follicles in the left. Her AMH was 1.8. So, Dr. Ramchandra sir, is myomectomy justified in this case, and who are the probable candidates for myomectomy in infertile patients? And do you suggest any precautions to be taken intraoperatively during the surgery?
As we know, suppose intramural more than 4 centimeters fibroids, definitely better to go for myomectomy. Submucous fibroids, definitely the size is not the criteria. We know the grading figures, better we go for myomectomy. Otherwise, we have seen if suppose the pregnancy is there, no right going 2 patients there, 6 centimeters is the fibroid size with 10 weeks pregnancy that came. But we don't, the people have advised termination outside. I think we don't advise them for termination at all. So if they are infertile, other causes are being thoroughly investigated. If it's more than 4 centimeters of intramural fibroids, we go for surgery. Submucous fibroids, we go for either hysteroscopic polypectomy or fibroid myomectomy, whatever depends upon, in my personal view. Madam, anything you can add?
So, according to ASRM recommendations 2017, in asymptomatic women with cavity distorting myomas, myomectomy may be considered to improve pregnancy rates. Myomectomy is generally not advised to improve pregnancy outcomes in asymptomatic infertile women with non-cavity distorting myomas. However, it may be reasonable in some circumstances, including but not limited to severe distortion of the pelvic structure, complicating access to the ovaries for oocyte retrieval. And intramural fibroids in close proximity to the cavity or that cause alterations in menstrual bleeding warrant removal prior to IVF. Some authors recommend myomectomy only for cases like repeated IVF treatment failures and fibroid-related obstetric complications and women with recurrent miscarriages. So, when considering myomectomy, few important points. Fibroids may not be the sole cause of subfertility. Fibroid mapping to be done prior to the procedure, and do not open the cavity during the surgery, and if open, not to suture the endometrium, suture the underlying myometrium in layers, and always obliterate the dead space, otherwise hematoma, necrosis and infection might lead to weakening of the scar. And always have a look at pouch of the POD following myomectomy to rule out endometriosis, and fibroids touching cavity with history of recurrent pregnancy loss need to be removed. So, yeah, hormones, male hormones were assessed. FSH was high, 10.8. LH was also on the highest side, 7.63. Total testosterone was normal, 312. Estradiol was normal. So, when do we say a patient is azoospermic, and is there any role of gonadotropins in such patients, sir? Suresh, sir.
Actually, zoospermia role for gonadotropins, there usually idiopathic hypogonadotropic hypogonadism. We can try gonadotropins. Usually, first line of drug usually use the HCG, and then we can go about monitoring the things. That is how usually it goes on. So there is always a role.
How long you suggest, sir, injections for these kind of cases, for duration of treatment?
Actually, bi-weekly it is usually given, unless and monitoring the testosterone levels bi-weekly it is given. So 1,500 to 2,500 units usually given. That is,
Thank you, sir. Thank you very much. So, the role of karyotype, let us know about the role of karyotype and Y chromosome microdeletion tests in azoospermia case. Karyotype abnormalities are the most common known genetic abnormalities that cause male infertility. Patients with such abnormalities should be counseled, and pre-implantation genetic testing of embryos should be offered given the potential risk of transmission of sex chromosome aneuploidy to offspring. Y chromosome microdeletions are the most common genetic cause of infertility in the male. Azoospermia factor region on the long arm of human male chromosome consists of 3 areas encoding genes involved in spermatogenesis: AGF A, B, and C. Knowledge of which region of AGF is microdeleted aids in clinical decision making, as men with complete deletions of AGF A and B should not undergo TZA for ART, and men with deletions of AGF-C have good prognosis, and also smaller partial deletions of AGF-A and AGF-B should be counseled that sperm may or may not be found with TZ. So, course at Oasis, IVF was done. It was an ANTAC protocol. Stimulation was given with recombinant FSH 225 and HMG 150. ANTAC was started from day 5. Pre-trigger E2 levels were 3206. She was given a dual trigger with HCG 5K and triptorelin 0.2. 10 were expected oocytes. She got 8 oocytes, out of which 7 were M2, 5 got fertilized, 5 got cleaved, and she got 3 day 5 blasts. And then because of recurrent implantation failure, she was suggested for PGTA. Out of these 3 day 5 embryos, 2 were euploid and 1 was aneuploid. And since she has history of previous total fertilization failure, total fertilization failure history in the previous stimulation, ionophore was used for oocyte activation. So, what are the causes of total fertilization failure? Let us quickly brush up. Total fertilization failure occurs in 5 to 10% of IVF cycles. It occurs in 2 to 3% of ICSI cycles. Fertilization failure in IVF is mostly related to sperm abnormalities, whereas in ICSI, oocyte activation defects are the frequent cause. Likelihood of recurrence in subsequent cycles is approximately 30%. Fertilization and pregnancy rates appear to improve after ICSI assisted oocyte activation compared to conventional ICSI. Sir, can you enlighten us on role of TISA in azoospermic men and the success rates and retrieval rates, sir? And if the sperms are not retrieved in TISA, what are the other options available for the azoospermic men?
actually, azoospermia, there are 2 types, obstructive and non-obstructive. So once synonymously we use non-obstructive azoospermia. Obstructive, we go about doing the surgeries related to it, vasovasostomy, vasectomy, and evaluation further. So that is altogether different. part of evaluation. So coming to NOA, non-obstructive azoospermia, actually present consensus is actually single session staged sperm retrieval techniques we are following. So it starts from NAB, needle aspiration biopsies. So we do 2 to 3 biopsies of the testes. So if you can retrieve some sperms, then we stop at that point. So if it is not, if we are not going well, so we go to the contralateral testes, 3 more biopsies of needle aspiration. Actually, TISA differs from NAB. TISA is a little different. TISA, we actually use a 22 gauge scalpel needle, and we usually go percutaneously and in different directions. That will cause a lot of maceration, post-surgery maceration, intratesticular bleeding, and after a few weeks, even the testis can go for an atrophy, and you can never retrieve sperms many of the times. So now we have made up the NAB technique, in which only unidirectional, in single direction only, we have to move the needle, and we use 18 gauge scalp inside, and this is one way of doing things. Then, so as we move, if we don't get on NABs, then there is seminiferous tubule mapping technique is there. So open real-time seminiferous tubule mapping technique is there. So in that, we open up the testis is delivered outside. We map 15 to 30 sites on one testis. So in this, actually, we use a 22 gauge scalpel to give a small prick, and we open up with a micro dissection forceps. We remove a small seminiferous tubule. So when in this way, there will be testicular damage will be less, and 30 samples from each testis can be done. So if this doesn't happen, then we can go to the contralateral testis, or we can proceed to micro TC. So which is the end point. Micro TC, as you know, it is a very morbid procedure, and whole test is almost sampled. So this is the end point, and needs all the above procedures can be done without a operating microscope. But micro TC requires operating microscope, which is a costly, very morbid for the patient. So up to 60% we can get it in micro TC. That is the end. Top of the ladder is micro TC. Bottom of the ladder is NAB, needle aspiration. TISA we are not doing. It's a NAB. What we do is actually NAB, or it is also called NTC, needle testicular sperm extraction. NTC or NAB.
Okay. Thank you very much, sir. So as infertility specialist, when we suggest TISA for patients, we usually counsel them prior by giving other options, as the surgical retrieval rate of sperms is just 40 to 50% with TISA. We advise them options of oocyte freezing on the day of TISA if there is no retrieval of sperms, or we also suggest them micro TISA if no sperms are found on TISA. And also, as a last resort, consent for donor sperm will also be explained priorly, only if the couples are willing. So she underwent laparoscopic myomectomy, and hysteroscopy was done. 2 fibroids were removed. Histopathology was normal. Cavity was normal on hysteroscopy. 2 months post myomectomy, scan done. Small 2 intramural fibroids, 1 to 2 centimeters, type 4, were present in the posterior wall. So injection leupride depot was given, 3.75 milligrams IM, and it was a down-regulated HRT cycle. ET was optimum, endometrial thickness was optimum, Dopplers were normal. 2 day 5 embryos were transferred for her, and beta HCG was positive. So take-home message is myomectomy not indicated in all infertile patients. Azoospermia, read the semen report, check if centrifugation done, and rule out spillage. Also rule out spillage. Azoospermia doesn't mean only donor gametes, and trial TISA should be opted only if there is semen freezing backup. So thank you very much. Thank you one and all. Thank you Dr. Suresh sir, Dr. Ramchandra sir, Dr. Durga ma'am, Dr. Manikandika madam, Dr. Padmaja madam. Thank you everyone. Now, that was an excellent session. Thank you so much to all the dignitaries. Now the time comes for the felicitation and respecting our seniors. Dr. Ramchandra sir, please felicitate Dr. Durga ma'am. Dr. Padmaja ma'am, thank you. ఇంకా Dr. Durga ma'am, can you felicitate Dr. Ramchandra sir? Sir is a well-known obstetrician and gynecologist since years in Tirupati, ma'am. Dr. Durga ma'am, can you felicitate Dr. Padmaja ma'am? Dr. Durga ma'am will felicitate now Dr. Neelima madam. Dr. Durga ma'am will felicitate now Dr. Manikarnika madam. Dr. Durga ma'am will felicitate Dr. Suresh sir, urologist. Thank you everyone. Vote of thanks will be given by Dr. Vote of thanks, Dr. Okay. So it's Thanksgiving time. We would like to thank the doctors who are present despite a busy weekday and have taken some time to attend the CME today. We would like to thank all the speakers of today afternoon. We would also like to extend my thanks to our entire Oasis team, starting from marketing, BD and operations team who have been working relentlessly to put their efforts on this program for over a month now. So, thank you, Durga.
On behalf of Government Maternity Hospital and Talks, I would like to thank Oasis Fertility for conducting this session. Thank you so much.
Now kindly join us for lunch, please. Thank you.